Hi, child development students. Today we're going to be covering Chapter 8, which discusses learning and behavior disorders. Lots of objectives for this chapter. So starting with number 1, by the end of this chapter, you should be able to describe the characteristics of a child with attention deficit hyperactivity disorder, also known as ADHD, and discuss intervention options. 2, identify various types of learning disabilities and including risk factors and describe response to intervention, RTI, as it relates to learning disabilities. 3, provide a description of behavior disorders including depression and anxiety. 4, describe Autism Spectrum Disorder and discuss recent research and effective intervention strategies. Finally, discuss elimination and eating disorders and when a teacher should be concerned. So think about what you already know about these topics, and you're going to be creating those schemas and those proverbial coat hooks in your brain to help attach information, new learning that you will obtain throughout the rest of this chapter. So take a moment just to reflect on what do you already know about these topics in our objectives. Attention deficit hyperactivity disorder. So the history of ADHD. It's been studied for more than 50 years, although it was discovered in the late 1800s. It's been studied for about the last 5 decades. The APA, the American Psychological Association, finally decided on ADHD with 3 patterns of behavior. So these 3 distinctions. 1, predominantly hyperactive impulsive type. The second one is predominantly inattentive type. And the third one is a combined type where you have elements of both previous categories. So those are the criteria for patterns of behavior to be established in order to get the ADHD diagnosis, according to APA. Current attempts at defining ADHD. You must rule out other causes. So ADHD shouldn't be a factor of something in the environment, for example, or other issues that would then explain why the child is hyperactive. So, maybe it's their diet and it's causing them to, if you're giving them, an espresso in the morning, then perhaps that would be the cause of the hyperactive behavior and not a legitimate diagnosis of ADHD. Clinical assessment of development as well as academic, social, and emotional abilities. And then we would also use checklists and rating scales to determine if those criteria are met for that diagnosis. What are some causes and prevalence of ADHD? There is no known absolute cause. So that's, I'm sure that's a little frustrating for those in the medical field and for families dealing with ADHD. However, there are some ideas as to what are some causes, and they have a fair amount of research to support them. So one would be possible cause being genetics. 1 or more parents is also hyperactive, and that would increase the probability that the child would also exhibit some of those same hyperactive characteristics. Another factor, according to research that has been discovered, is maternal smoking or drug alcohol use during pregnancy. So that might also be a factor for ADHD. There are also some comorbidities. So these are other disorders that sometimes accompany ADHD, and those include learning disabilities, oppositional defiant disorder, conduct disorder, anxiety disorder, and depressive disorder. So oftentimes, if a child is diagnosed with ADHD, then they also may have accompanying that diagnosis some of these other diagnoses as well. What are some intervention strategies to help mitigate or alleviate some of the symptoms of ADHD or the side effects or the behaviors? One would be medication and behavior management, and combined, those seem to be the best approach. With regards to medication, psychostimulants are the most common. That would be medications like Ritalin. Increased attention and concentration, decreased impulsivity and activity. Side effects, they can cause sleep disorders, weight loss, and increased blood pressure. So there's obviously both benefits and drawbacks to using medication for ADHD. There's also special diets that can be used to help mitigate some of the characteristics of ADHD. The Fine Gold diet is one tried method where you eliminate food additives and salicylates. I don't know if I'm saying that right. Salicylates. Parents feed the child additive and dye-free foods to lessen hyperactive behaviors. Nutrition is key, but eliminating foods does not 100% solve the problem. So it might help, but it won't necessarily cure the condition. Behavior management is also a huge factor for ADHD. Some recommendations from the text are to reward positive behaviors, evaluate the environment for a match between the environment and the child to manage his or her own behavior. So thinking about whether there's distractions in the classroom, is the environment set up in a way that's conducive for the child to be able to focus when needed and to be able to move around and expel energy when needed as well. Plan developmentally appropriate activities for all children so that children are not inappropriately labeled. So you need to make more modifications in the environment versus trying to get the child to adapt to an environment that's inappropriate and then labeling the child as a result. Learning disabilities. So this is a disorder in one or more of the basic psychological processes involved in understanding or in using language, spoken or written, which may manifest itself in the imperfect ability to listen, think, speak, write, spell, or do mathematical calculations. And the textbook talks about kind of a dilemma where early childhood teachers find it difficult, or I guess the idea is, can an early childhood aged child be considered learning disabled or have a learning disability, I should say, for person first language always, if they're not to the level that they should be doing these things yet anyway. So how would you make that determination is kind of the idea behind this conundrum. So what do you think? Can a child who is 2 or 3 or 4, maybe before their literacy and numeracy skills are not quite developed, can we determine that they are learning disabled if we're going to use this criteria? So some food for thought, something to ponder. So another criteria for a learning disability is that it is not the result of these other factors, including visual, hearing, or motor handicaps, emotional disturbance, environmental, cultural, or economic disadvantage, and second language learning. In my previous experience, I've often found that sometimes children who are second language learners are categorized or classified, labeled as having a learning disability, when in fact we're looking at the fact that they are still acquiring a second language. It's not a learning disability. So you'll find oftentimes the children of color and children who are second language learners are diagnosed with learning disabilities at a higher rate. And so we're trying to combat that. Education is trying to combat that by having these kind of preemptive regulations or guidelines in place to make sure that that happens at a lower rate. And that is tied to this next idea, which is the non-disadvantage ruling. This is interesting. This excludes children who live in environmental or economic disadvantage from being labeled learning disabled. So, in other words, because research shows that there are other factors that can contribute to children's academic success or challenges with academic achievement, then we have to try to remove those variables from a diagnosis or a label of learning disabled, having a learning disability. Academic ruling is the definition that there should be difficulty in reading, writing, spelling, and mathematical calculations. And again, kind of back to that conundrum from the previous slide, at what age do we determine that this is a factor or criteria? What are some risk indicators for learning disabilities? How do we predict learning disabilities? Well, one, we can observe the child, match observation to performance measures, but proceed with caution. So children can develop skills in a range. So we need to look for deviations from the range as a sign of possible learning disability. So because children grow and develop at different rates, we need to keep that in mind. And just because someone is a little bit delayed, we don't want to jump to the conclusion that they have a learning disability. We need to keep in mind that a certain range of variation in development is normal. So monitoring, observing, continuing to document the development and measuring growth from one point to the next is probably a better way than just a blanket, well, by this age they should be doing this, and if they're not, then they have a learning disability. There are also prerequisite skills to consider. These are skills that are needed to enter school. So the skills that would deem a child school ready. So what kind of skills would those be, do you think? Okay, so maybe things like recognizing shapes or knowing their name, being able to tie their shoes, those sorts of things maybe perhaps would be some of the skills needed to enter school. Being able to follow directions, being able to sit at a table for, short periods of time, etc. So it's not just academic skills, but it can also be social skills that would be determined school ready. So it comes through experience, learning, and the opportunity to practice and master developmental skills. There are also sensory motor difficulties that fall under the category of learning disability. So with regards to gross motor, so that would be, for example, imperfect body control, poor balance, uncertain bilateral and cross-lateral movements, inability to cross body midline. So you can see the picture above. If your child can DAP, then they can cross midline. So that's something that my son Colson, for example, would work on in therapy. So when you have an infant or a toddler grabbing something, they often, are grabbing out to the side, so lateral. But if we get them to grab something with this hand crossing over to grab it over here, that's crossing midline. And so that's a skill that needs to be developed. So inability to cross body midline would be an example of sensory motor difficulties. And then also we have faulty spatial orientation. So with fine motor, sensory motor difficulties, we have issues with problems in buttoning, lacing, snapping, tying, cutting, pasting, and stringing beads, perseveration, or repeating the same actor words. So where they're kind of stuck and they're doing the same thing over and over. Cognitive disorders can include trouble organizing thoughts or processing information logically. Abstract thought is difficult, poor memory, and then problems with generalizing information. So being able to apply information from one concept to the next. Visual and auditory perception problems include visual discrimination, visual orientation, visual memory, visual tracking, visual motor integration, and auditory perception problems. Language delays can include both receptive language and expressive language. So receptive language would be the language that you understand or comprehend. So if you tell your child, can you take off your shoes and put them in your closet, if they follow those instructions, then you might assume that they have receptive language. They can understand the spoken word. Expressive language is a child's ability to express themselves verbally. So for them to be able to say, "Mommy, I took off my shoes," that's expressive language. There's also social skills delays that fall under learning disabilities categories, and that could include bullying, being withdrawn, aggressive, and being overly dependent, over-dependent. Response to intervention. This allows a teacher to intervene with a child without there being a required discrepancy between ability and achievement. So these are kind of in-class levels of differentiated instruction that a teacher can address the needs of the varying levels of children in their classroom. Tiered approach is screening and group interventions, target and short-term interventions, and intensive instruction. We'll see a sample pyramid on the next slide. So pre-K RTI, high-quality instruction, tiered instruction and intervention, ongoing student assessment and progress monitoring, and then family involvement is also a very important part of it. So if you notice on the tiers, we have the lower tier. This is where the teacher is addressing the needs of the majority of the students in the classroom using differentiated instruction. And then the students who aren't quite getting it would be in tier 2. So these are students who lag they lag behind their peers and demonstrate weak progress on screening measures and require some form of intervention. And then the top tier are for the students who, even after tier 2, they're still needing additional support. And so these are students who may lag behind their peers 1 or more years. And so you can see that with response to intervention, as the needs increase, the tiers increase. So if you're a tier 3, then you have higher needs than somebody who is at tier 1. Program considerations. All children at some time or another will show some signs of a learning disability. So it doesn't mean that they are necessarily diagnosed with a learning disability, but the signs might be evident. Children need environments that are positive and developmentally appropriate. Schedules need to be consistent. Think about consistency. Think about in our own lives how consistency really helps us to perform and focus. Tasks need to be broken down into smaller chunks of information. And again, I feel like a lot of these categories we can say would apply to us as adults as well. There are also behavior disorders to consider. Behavior in these cases is extreme, chronic, and unacceptable. So it's not just something that happens once in a while when you take away the iPad or you're at the store and they can't get that toy in the impulse aisle, at the checkout. It's when it's chronic, it's happening all the time, it's extreme, and it's unacceptable. So the definitional issues, experts who work with these children prefer the term behaviorally disordered. Say that again, behaviorally disordered, because it places the focus on the observable aspect of the children's problems, which is the behavior that's causing problems in school and at home. The term emotional or behavioral disorder means a disability characterized by behavioral or emotional responses in school so different from the appropriate age, cultural, or ethnic norms that they adversely affect educational performance. So they have to be pretty much an outlier to be considered a disability with regards to behavior. Emotional and behavior disorders can, and often do, coexist with other disabilities. What are some other disabilities that we've learned about so far in this class that you think might correlate or might occur frequently with emotional and behavior disorders? What are some thoughts you have there? Okay, maybe look back in the notes or in your text and see what you think. This category may include children or youths with schizophrenic disorders, affective disorders, anxiety disorders, or other sustained disorders of conduct or adjustment when they adversely affect educational performance in accordance with Section 1, Fornes and Nitzer, 1992, page 13. The prevalence, 1% of school-age children are identified with serious or emotional behavior disorders. Behavior problems may also be seen in preschool-age children. Intervention is imperative when the behaviors are becoming a child's habitual way of responding to stress and frustration. Depression. Depression can be defined as changes in emotions, motivation, thoughts, and physical well-being. Children growing up with depressed parents are likely to have bouts of anxiety and depression. So we can say it's partially nature and nurture. Low self-esteem may also be associated. Anxiety. People who experience excessive fear, worry, or uneasiness. Some fears may even become phobias. Fears are normal, but when taken to the extreme, they can cause multiple maladaptive behavior. So remember, these disorders are on a continuum. So everybody has a level of fear or anxiety, and we all maybe feel down and depressed. But this is when these symptoms are so chronic and almost debilitating that they really adversely impact their day-to-day living, socially, cognitively, at school, etc. And autism spectrum disorders are usually present by age 3. So I would say between the ages of 18 months and age 3, that is when parents may start seeing signs and getting the child assessed and evaluated with perhaps a developmental pediatrician. And with autism, there are deficits in social communication and social interaction. There can be restricted repetitive behaviors like spinning wheels, what we call stimming for stimulation, like flapping hands, interest and activity. So they might have very, very specific interests that they really focus on. So maybe it's cars, maybe it's toy cars. And so you feel like the child has an obsession, an extreme obsession with toy cars, for example. The prevalence of autism, it occurs more in boys than in girls. Identification is increasing over the years. I'm sure you're aware that the occurrence of ASD diagnoses is definitely on the rise. More children are being diagnosed by the age of 3, which is good in the sense that because it's at this age, then they can get early intervention, because early intervention, children age out at 3. So if you're diagnosing a child after 3, it might be harder to get services, or there may be fewer services available. An overlapping condition that varies from child to child. So it can occur with other diagnoses and disorders as well. There are advances in autism research. One is genetic links. There are mutations seen in children who have older, more mature fathers. There is just a slight association with the mother's age. There's also the impact of environmental pollutants. Pesticides may increase the risk of autism. There are high levels of air pollutants during pregnancy. If there are high levels of air pollutants during pregnancy and the first year of life, that also may increase the risk of autism. Problems that may accompany autism spectrum disorder would include intellectual disabilities, seizures, Fragile X syndrome, and tuberous sclerosis. Other forms of ASD include Rett's disorder, and this is a disorder predominantly found in females. Typical development for 18 months, then loss of abilities in gross motor, speech, and hand use. So this can be rather alarming for a parent who thinks that their child is developing typically, and then around 18 months, and they start to regress in their abilities. Attention deficit hyperactivity disorder is also something that may be found with ASD as well. Some interventions would be applied behavior analysis, also known as ABA, discrete trial training. The best approach is an individualized approach, so it's not one size fits all. I once heard this saying that, well, if you know one kid with autism, you know one kid with autism. So in other words, it's not like the typical saying is, well, if you've seen one kid with autism, you've seen them all. It's quite the opposite. If you've seen one kid with autism, you have to understand that those characteristics, whatever perceptions you have, apply just to that child. And you can't blanketly apply those ideas or descriptions to all other people that you meet with autism. Other interventions can include dietary interventions, food allergies, and insufficient vitamins or minerals. One of my best friends have 2 sons that had an autism diagnosis. Donna Molina, who perhaps you've seen in the speaker panel video assignment, and she's very, very disciplined and very conscientious about the diet, where it's gluten-free, casein-free, and it's shown great benefits to both of her boys. And so she would attest that the diet is a huge factor and has helped her family tremendously. There's also something called chelation, which is removing heavy metals from the bloodstream. So this is something that can be done either through IV fluids or through pills, where the medication, once it gets into your body, it binds to the whatever metallic substances, whether it's lead or arsenic, etc., binds to it, and then it comes out when you urinate. So that would be chelation as an intervention approach. Medications used to treat behaviors such as aggression, self-injury, and tantrums. So even though there's no cure for autism, the idea would be that some of the some of the symptoms or attributes of autism can be addressed with medication, the aggression, self-entry, and tantrums. Pica. Pica is the craving of non-food items. So we know that toddlers and little ones go through Piaget sensory motor stage where everything goes into the mouth. And that's not pica. Pica is much more severe. It's not within the normal range of children putting things into their mouth. This is when they crave non-food items. So if you see those, those shows on Lifetime or My Strange Addiction where people eat, I've seen people eating detergent powder and things like clay or motor oil or something strange like that. So pica is when a child or a person craves non-food items. There's also soiling and wetting. Persistent wetting may be signs of an infection, so that's enuresis, bedwetting. The child may have an intestinal virus. Diabetics also have trouble with bladder control. Also, strained bathrooms may cause undue stress on a child. So thinking about the environment itself and how that may impact the child's ability to go to the restroom. And a final but important note. Every child can exhibit behavior problems at one time or another. I'm sure we all know that very well. It is cautioned to not prematurely label a child. And it is not how a child is classified, but how a child is cared for. That is the most important issue when addressing behavior and learning problems. So let's go back and revisit our objectives and see what new information you've learned that you can add to your prior knowledge. So first, describe the characteristics of a child with attention hyperactivity disorder and discuss intervention options. Next, identify various types of learning disabilities, including risk factors, and describe RTI as it relates to learning disabilities. Then, provide a description of behavior disorders, including depression and anxiety. Next, describe autism spectrum disorder and discuss recent research and effective intervention strategies. And finally, discuss elimination and eating disorders and when a teacher should be concerned. So hopefully you've learned a lot in this chapter. It's a lot of useful information. Thanks so much for listening. See you next time.